Hello, I'm Rebecca Jane Collins. Today, we're diving into one of the most physiologically demanding challenges in anesthesiology, the complete perioperative management of the burn patient.
This explainer is really for you, the practicing anesthesist. We're going to provide a comprehensive guide to navigating the complex systemic chaos that a severe burn inflicts. The goal is to equip you with the critical knowledge you'll need to manage these patients safely through their entire operative journey.
We're going to follow the patient's journey, step by step. We'll start with that initial evaluation, then dive into the tricky pharmacology, walk through the hands-on intraoperative management, cover postoperative care, and finally, wrap up with the huge topic of pain management. I'll get us started, and then you'll hear from my colleagues as they guide you through the subsequent sections.
All right, let's begin with the absolute first step, getting a true grasp of the profound, multi-system physiological disruption caused by a severe burn. You have to understand, this isn't just a skin injury we're dealing with. It's a full-blown systemic disease.
The very first point of assessment is the burn itself. Its depth is paramount because it basically dictates the entire clinical course ahead. A superficial burn, just affecting the epidermis, is painful, no doubt, but it will typically heal on its own. A full-thickness burn, on the other hand, that's a different beast entirely. It destroys all layers of the skin, even the nerve endings. These injuries have no capacity to heal spontaneously and will always require surgical intervention, meaning debridement and skin grafting.
Next up, we have to quantify the extent of the injury. Getting an accurate estimate of the total body surface area, or TBSA, is absolutely fundamental. It guides our fluid resuscitation and helps us predict outcomes. For adults, the rule of nines is a fantastic tool. It's rapid, it's effective, and it assigns multiples of 9% to different body regions. But for children, it's a different story. Their body proportions are different. That larger head-to-body ratio is key. So the Lund-Browder chart you see here is the much more accurate and essential tool to use.
Okay, so our preoperative assessment has to be systematic. It has to be thorough. This table really summarizes the core domains we need to think about. We're looking at general factors like the patient's age and the mechanism of the burn. For instance, an electrical burn should make you think about deeper, hidden muscle damage and a higher risk of myoglobinuria compared to a thermal burn. We must have a high index of suspicion for airway involvement, especially with any burns to the face. We need to know the time since the burn so we know exactly where the patient is in that crucial resuscitation phase. And of course, we absolutely must account for any pre-existing conditions that are going to reduce their physiological reserve.
This slide really drives home how a burn ignites this massive inflammatory cascade. This is not a localized event by any stretch. On the respiratory front, inhalation injury is a major killer. It causes upper airway edema and lower airway damage that can rapidly progress to acute respiratory distress syndrome, or ARDS. Cardiovascularly, patients initially present in what we call burn shock, a nasty combination of distributive and hypovolemic shock with a profoundly decreased cardiac output. Hours later, this is followed by a massive hyperdynamic state. The kidneys are at extreme risk from hypoperfusion, which leads to a shockingly high rate of acute kidney injury. And finally, the body kicks into this intense hypermetabolic state, which is proportional to the burn size. This dramatically increases oxygen consumption, CO2 production, and nutritional needs, making thermoregulation in a cold operating theater a constant uphill battle.
Thanks, Rebecca. So, building on those profound physiological changes, let's turn to a really critical area: how this completely altered physiology fundamentally changes a patient's response to the very drugs we rely on. Let me be clear, standard protocols do not apply here. You can throw the textbook out the window.
And that is the vital question, isn't it? Well, the answer lies in these dramatic shifts in both pharmacokinetics and pharmacodynamics. You have these massive fluid shifts that increase the volume of distribution for our hydrophilic drugs. You have altered protein binding, especially a big drop in albumin, which increases the free fraction of highly bound drugs, potentially to toxic levels. On top of that, both hepatic and renal clearance become wildly unpredictable. This creates a scenario where we absolutely must titrate every single drug to effect, because standard dosing is not just unreliable, it's downright dangerous.
Now, central to this whole pharmacological puzzle is a concept you have to understand: acetylcholine receptor upregulation. After a major burn, the skeletal muscle cells start to express a huge number of immature extrajunctional acetylcholine receptors, specifically this alpha-7 nicotinic subtype. It's the proliferation of these receptors, which are normally just confined to the neuromuscular junction, that is the key pathophysiological event that explains the bizarre and dangerous responses we see to muscle relaxants.
And this brings us to the single most dangerous consequence of that upregulation. This is a big one. When succinylcholine is administered, it acts as an agonist at all these new, widespread extrajunctional receptors. What does that do? It triggers a massive, uncontrolled efflux of potassium from the muscle cells. The result is a sudden, severe, and often fatal hyperkalemia. This risk begins about 24 hours after the burn and can persist for up to 2 years. So, succinylcholine is absolutely contraindicated during this entire period. No exceptions.
Now, the flip side of this upregulation phenomenon is the response you get to non-depolarizing muscle relaxants. The sheer number of available receptors creates a state of profound resistance. The standard dose of a drug like rocuronium just won't be enough to block enough receptors to achieve paralysis. Consequently, we have to be prepared to use significantly higher doses, we're often talking 2 to 3 times the normal dose, to achieve adequate surgical relaxation. And of course, this must always be guided by neuromuscular monitoring.
Right then, now that we've got our heads around the pharmacology, let's apply it. Let's move into the operating theatre and talk about the practical, hands-on techniques for anesthetic management. This is where the theory really meets reality.
Airway management is, without a shadow of a doubt, our #1 priority. A patient with facial burns or suspected inhalation injury is a ticking time bomb. The edema is progressive, it's relentless, and it will not wait for you. The golden rule here is to secure the airway early and in a controlled manner, long before it becomes anatomically impossible. A fiber optic bronchoscope is an invaluable tool in these situations, and once the tube is in, well, that's another challenge. Standard tape just won't stick to burned or edematous skin, so you have to be prepared to use unconventional methods, like suturing the tube in place or using circummandibular wires to make sure it stays put.
Okay, monitoring. It's completely non-negotiable. An arterial line is mandatory. You need that beat-to-beat blood pressure analysis. A central line gives you reliable access for vasopressors. An indwelling urinary catheter is your primary guide for fluid resuscitation. You're aiming for about 0.5 to 1.0 milliliters per kilo per hour in adults. Core temperature monitoring is also absolutely essential, as these patients lose heat at an incredible rate in a cold OR. And let's talk about access. You will often have no choice but to place large-bore IVs directly through burned tissue. Yes, this increases the infection risk, but it's a necessary, life-saving measure.
Your choice of anesthetic agent is critical. For a hemodynamically unstable patient in the acute phase, ketamine is very often the agent of choice. Its sympathomimetic properties help maintain blood pressure, it provides profound analgesia, and it's a bronchodilator, a triple win. In contrast, agents like propofol and thiopental are potent vasodilators. That makes them less than ideal for that initial, unstable phase, though they might be useful later on during reconstructive surgeries in a more stable patient.
Surgical debridement is intensely painful. We need potent analgesia to blunt the massive surgical stress response this causes. So high-potency, short-acting synthetic opioids like fentanyl and sufentanil are absolute workhorses here. As you can see from the table, they provide excellent analgesia while maintaining a much greater degree of cardiovascular stability compared to something like morphine, which can cause histamine release and vasodilation. In this timeline, this outlines the cornerstone of early management, fluid resuscitation. The Parkland formula is the classic starting point. 4 milliliters of lactated Ringer solution multiplied by the patient's weight in kilograms and the percentage TBSA burned. But the key here is the timing. Half of this calculated volume must be given in the first 8 hours, and that's from the time of the burn, not from their arrival at the hospital. The second half is then administered over the next 16 hours. But remember, this is a guide, it's not a prescription. The rate must be continuously titrated based on the patient's response, and you're primarily watching their urine output. So the conclusion of surgery is not the end of the challenge, not even close. It's simply a transition to the next phase of critical care. Let's talk about the vital considerations for that immediate postoperative period. The handover to the ICU is a moment of maximal vulnerability for the patient. Our priorities have to be crystal clear. First, we must continue the battle against hypothermia. These patients have lost their primary thermoregulatory organ, their skin, and they've been exposed for hours. Aggressive warming must continue unabated to prevent coagulopathy and cardiac instability. Second, most patients with significant burns will remain intubated and will require ongoing mechanical ventilation. Third, the resuscitation doesn't just stop when the surgery does. The massive fluid shifts will continue, and that requires diligent monitoring. And finally, a clear, structured handover to the ICU team is absolutely essential for a safe continuity of care. And for our final section,
We'll discuss what is arguably the most significant and enduring challenge in burn care, managing the patient's severe, complex, and multifaceted pain.
The most crucial point to grasp here is that burn pain is not a single thing. It's a dual challenge. First, you have the background pain. This is a constant, gnawing, moderate-intensity pain that's present even when the patient is at rest. This requires a baseline regimen of scheduled, often long-acting analgesics. But then, on top of that, you have procedural pain. This is the excruciating, severe pain that happens during interventions like daily dressing changes. And this requires a completely different approach. Preemptive, potent, short-acting analgesia.
So a successful strategy has to be multimodal, as this table illustrates quite well. We can't just rely on opioids. We treat background pain and anxiety with scheduled agents, like methadone and lorazepam. For procedures, we use preemptive boluses of short-acting agents, like midazolam for the anxiety, and potent analgesics like ketidine or fentanyl for the pain. Ketamine is particularly useful here. It provides profound analgesia at sub-anesthetic doses, and it also helps to combat opioid-induced hyperalgesia. That makes it a really powerful tool for managing the extreme pain of things like dressing changes.
And that brings us to the end of our deep dive. You know, the continuous evolution of surgical techniques and our understanding of burn pathophysiology demands that we, as anesthetists, constantly refine our approach. Managing these critically ill patients is the ultimate test of our skills in physiology, pharmacology, and critical care. The goal isn't just survival, it's a functional recovery, and our management in the perioperative period truly lays the foundation for that outcome.